Hello everyone, my name is Asia Jewell and this is the video assignment for medical terminology. So the different medical journals that I chose, I went off a little bit more than 3, but I chose to do the endocrine system. And with the endocrine, I chose to do the different types of thyroid cancers. So the first article is titled The Identification and Treatment of Different Thyroid Cancers, and it's written by Cord Sturgeon, MD, and Peter Angelos, MD/PhD. So, as you could guess with just the title of this article, it's basically just generally talking about the different types of thyroid cancers and how to treat them and the different risk factors and what comes with basically being a patient with thyroid cancer. So, for this article, I just basically wrote down the synopsis of it, just kind of explaining what thyroid cancer is in general and went from there. So most thyroid cancers are actually slow growing and easily treatable. They also have excellent prognosis after surgical resection and targeted medical treatment based on the type of cancer. So basically, in a lot of cases with thyroid cancers, full thyroidectomies happen, which you can't live without your thyroid. So there's a lot of risk factors that come with it. So they're kind of experimenting now to see what else there is out there other than full thyroidectomies. Thyroid cancers originate from either the follicular cells or the parafollicular C cells. And follicular cells are the largest cellular component of the thyroid. It's from these cells that the following 3 types of cancers arise: papillary, medullary, follicular, and anaplastic. Anaplastic cancers probably arise from a follicular cell cancers that have undergone dedifferentiation and represent less than 2% of thyroid cancers. So I put down that, so this is completely quoted. That was completely quoted from my first article. I've got it quoted here, and then I went out and to define the differentiation. It's an important biological phenomenon, basically, where cells regress from a specialized function to a simpler state. So I'm just going to start with a little bit into kind of the smaller two. Not really the smaller two, but the smaller percentages of the two, and kind of work my way up. So the smallest of the two, or smallest of the 4 that I'm explaining right now, is anaplastic. So anaplastic thyroid cancer has the poorest prognosis of all the types of thyroid cancer. In fact, it's one of the fastest growing, most aggressive human malignancies. Survival is measured in months rather than years, with an overall median survival for 3 to 4 months, and death is usually by asphyxiation. So the peak incidence is in the 7th decade of life. So when they're 70 years old is usually when people get anaplastic thyroid cancer. Most patients are female, and most of the tumors grow to be 8 centimeters or larger. So that's why they kind of, that's why they usually are passing from asphyxiation, because there's a lot of pressure into your throat and you're not going to be able to breathe because you have this tumor that now just keeps growing. And that's one of the biggest symptoms of anaplastic. So on from anaplastic is medullary. So medullary thyroid cancer, this one kind of derives from the parafollicular cells, so C cells, which produce the hormone known as calcitonin. So basically your body needs calcium in its blood to function. And so the C cells produce the hormone that kind of creates the calcium into your blood, the calcitonin. It's hereditary. Medullary is a 10-year survival rate is usually about 75 to 85%. Half of these patients actually will have it localized to just the thyroid gland, and those patients that have it just in the thyroid gland, their rate of survival for 10 years is up to 95.6%. This one is actually, I've got it from a different article, because the first article that I had read didn't really include a lot about medullary. It included quite a bit about papillary and follicular and touched a little bit on anaplastic too, but not really medullary. So I had to dig a little deeper to find this. And this one was from, it's called The Oncologist, and it's written by Rebecca Sippel, MD. So anaplastic usually is about 2% or less, give or take, and then medullary is about between 5 to 10 different different sites say between 5 to 10%. So medullary is usually, it's the lower of the two. So medullary and anaplastic are two of the least commons of thyroid cancers. So then you get into the follicular thyroid cancer. It's the second most common type of thyroid cancer. It accounts for approximately 1 out of 10 cases. It is found more frequently in countries with, a bad dietary intake of iodine. So follicular carcinoma is also a differentiated form of thyroid cancer. In most cases, it's associated with a very good prognosis, although it's somewhat more aggressive than papillary cancer. Follicular carcinomas don't usually spread to nearby lymph nodes, and they are more likely than papillary cancers to spread to other organs, so like the lungs and the bones. So papillary, I keep saying the wrong word. Papillary cancer actually has been known to kind of jump to other lymph nodes and infect different lymph nodes in your neck, and therefore, like when you're getting a full thyroidectomy from having papillary thyroid cancer, you're also getting damage to your other lymph nodes in your neck, which could cause further damage into your body and how your body functions. So the follicular thyroid cancer actually accounts for about 20%. So it's a lot more than medullary and anaplastic together, but the highest known and most common type of thyroid cancer is called papillary. So the papillary thyroid cancer accounts for approximately 80% of cases. I know it doesn't add up to complete 100%. There's got to be a little bit of room for error, couple percentages. Papillary carcinomas, they're slow growing. They're differentiated cancers that develop from follicular cells and can develop in one or both lobes of the thyroid gland. This type of cancer can spread to nearby, like I had said with follicular, that usually spreads to other organs. Papillary usually spreads to other lymph nodes in the neck. It's generally treated and it has a good prognosis, a survival rate. It's kind of known as, if you're going to get cancer, this is the cancer that you want, essentially, because it's survivable and it's treatable. You have a very good live rate. It's basically, like I said, it's the cancer that you want. So this one is actually from another article I kind of touched on. This is my third article that I did a synopsis on, and it's basically the management of papillary thyroid cancer. And it's written by Rena. Don't want to say the last name because I probably am going to butcher it, but I'll try. It's Vassilopoulou /Selin. She's MD and FACP. And then, so I'm going to kind of jump a little bit more into papillary cancer. So essentially, the 4 different types that I've talked about, there's anaplastic, medullary, follicular, and papillary. So actually, I believe the papillary, the most common one, I actually do have a patient statement from somebody. I do have all rights to kind of release this information to you guys, kind of talk about it. She gave me, all permission to use this for my class. So we're going to, from now on, we'll refer to them as patient A, age 30. Now, their diagnosis was multifocal papillary thyroid cancer. So the timeline of diagnosis and treatment, patient now referred to as patient A. I'm just going to kind of go over a little bit of kind of what she went through when she was diagnosed with papillary thyroid cancer. So in 2008, there was a lump in the neck. Patient A did not notice, but her primary care doctor did. The biopsy was done, came back negative. Original thoughts were that it was a cyst. So they drained the cyst. It ended up coming back, and patient A never noticed it or had any issues with it. But patient's spouse could know that he could notice it, especially when the patient was lying down. So when the patient was lying down, it was kind of visible, but the patient themselves never really noticed it. 2010, patient A moved. So they moved from, I want to say, from, I think it was about 350 miles or something. They moved, so they had to get a new primary care doctor. So they followed up with the new primary about the previous biopsy. The new primary felt lump and wanted a second opinion. The patient was sent to an ENT. So an ENT doctor is a ear, nose, and throat doctor. They then referred them to an endocrinologist for a second biopsy, and the biopsy came back positive. So in 2011, in February, the diagnosis of positive biopsy was concluded as papillary thyroid cancer. The patient was sent back to an ENT to schedule the first available surgery for a full thyroidectomy, which is what we discussed a little bit earlier. They are looking at different ways to figure out how to avoid doing full thyroidectomies because, again, you can't live without your thyroid. So we'll go on and I'll explain a little bit more of what she has to live with day to day without a thyroid. The patient scheduled surgery for March 17th. So she was diagnosed in February. She was scheduled to have a full thyroidectomy in March. So in surgery, they removed 10 central compartment lymph nodes. A week later, the diagnosis was confirmed as multifocal papillary thyroid cancer, which metastasized into one lymph node. So patient A was immediately put onto medicine known as Synthroid, calcium, and calcitrol due to their parathyroid glands being damaged during surgery. This resulted in hypocalcemia. So she had to be, Synthroid is a thyroid hormone. She no longer has a thyroid, so she has to replace that thyroid hormone with something, something alternative. She doesn't have something that's going to be controlling her metabolism anymore, so now she has to replace it. And then the calcium and calcitriol they're both basically to replace, to kind of fix what happened with the parathyroid glands that were damaged during surgery. Patient A was then kept on a moderate dose of Synthroid for approximately 2 months. Then they were required to stop altogether for 6 weeks to prepare their body for radioactive iodine ablation. So 2 weeks prior to RIA, they had to start a very strict low iodine diet. When patient A started treatment, they had to leave their family for 2 weeks after treatment due to high levels of radiation. So essentially, they brought patient A in, and the doctors took multiple pre-treatment full body scans, and then they administered the radioactive iodine, which the patient had to drink. It was kind of just like nuclear Kool-Aid, essentially. They had to drink it, and then they had to take multiple post-treatment full body scans to make sure that the treatment was actually targeting the appropriate area. After 6 months, the patient returned for a follow-up post-treatment scan, which showed no evidence of disease. Then, for the first few years following treatment, the patient was required to get follow-up blood tests for thyroglobulin, which is a cancer marker. Patient A now goes once a year for a follow-up lab work, but it has been undetectable ever since, and the patient is required to follow up for 20 years after the initial diagnosis. So for the first couple years, she had to, I think it was for the first year or two, they had to return for, I think, every 6 months, and then after that, it was once a year they had to return to get checkup and follow-up labs to make sure that it's not coming back or, just showing up in somewhere else. So some notes about this case: surgery concerns. With every surgery, there's always a possibility of death. In this patient's case, they kept an emergency kit bedside due to the fact that internal bleeding risk is very high with thyroid surgery. So this kit was kept close so that if something were to happen, they could immediately open the patient up to attempt to stop it. Another risk in this particular patient was potential damage to the vocal cords due to how large the thyroid had grown and how the tumor was wrapped around it. But the patient had no complications post-op in surgery. It was just the tumor had grown so much, so when they were removing it, there was damage to the parathyroid glands. But other than that, during surgery, there was no immediate risk of, further harm down the road. Essentially, there was no risk of death or anything. She never started to bleed out, and I'm starting to use I've noticed it a little bit, but Synthroid is a thyroid hormone, so we're going to touch a little bit on that before I get on to the ending here. So Synthroid's a thyroid hormone. As I mentioned before, you can't live without your thyroid without being on a hormone to replace it. The patient is now on that, as well as Cetamel, calcitriol, and calcium for the rest of their lives. So the patient now has to take these medicines as well as anything else that she has to take for any other conditions, just to stay alive. If they don't take this Synthroid, she starts to get very ill and she will die within days of not having this medicine. So Cetamel is an additional thyroid hormone. So essentially, they're taking synthroid cetamol. Those are both thyroid hormones to kind of help the patient. The patient has struggled with losing weight, for instance. That's a good example. So when you don't have a thyroid, you no longer have a metabolism. Even the medicines that you take to replace your thyroid hormone, it doesn't exactly help you lose weight. It's next to impossible without a thyroid to lose weight. But you can keep gaining weight because you're still eating, and even though you're eating healthy, you're working out, it's almost impossible to lose weight. So they put her on an additional thyroid hormone to kind of increase her chances to start losing weight and try to feel better about herself. And then she's also on 2 different types of calcium medications because of, again, of the hypoglycemia. So they're taken again, for the hypoglycemia, the calcitriol and calcium, they're taken for low blood calcium levels due to the previous parathyroid damage from the surgery. That's what I got written down. That's kind of what I've, talked about a little bit with you guys. But essentially, the patient was young. The patient was very young. The patient was scared. They had no idea there was a lump in their neck, and then all of a sudden their primary and their spouse told them there was a lump, and they thought it was a cyst. It was drained. A few years later, they're back at the doctor's office. Oh yeah, this lump came back. Second biopsy done, you have cancer. So essentially, when I had kind of touched back on the 3 different synopses of the different articles that I read, essentially, again, if you're going to get cancer, this is the type that you want. All cancers are awful. All of them have horrible side effects. But if you are going to want one, or going to not want one, no one ever would want one. If you're going to get one, this is the one that you would want and pray to be diagnosed with. So papillary therapy, it's the patient, this is kind of tying into, why did I choose the endocrine system? Why did I choose to talk about the different types of thyroid cancers and why some of them are like extra scary, and then some of them, like papillary, are almost a godsend. When you hear the word cancer, you're just terrified, but papillary thyroid cancer, when caught as early as it was, it could have been caught earlier had there been a second opinion done earlier. So this patient, she's now 38 years old. Yes, I'm using she again. She's got 5 beautiful kids, one of which who came a year and a half after her thyroidectomy, when she was not supposed to have children again. She wasn't supposed to be able to after the radioactive iodine treatment. The child that came after that, she was very high risk. She ended up having to travel 400 miles down to University of Michigan Hospital to have her child there. And she lived down here for a month before her due date because of the fact that she wasn't supposed to even get pregnant again. The reason that I chose this topic is because patient A is my mother, and she is doing great. And I'm very thankful that she is alive, and that when we got the diagnosis, we were terrified. But papillary thyroid cancer, the doctors were very helpful. They were very explanatory, and she does have to take medicine for the rest of her life. But she actually was just cleared from the oncologist department, just had her cancer checkup, and she no longer has to return to the actual hospital for her follow-up labs. Now she can just return to her primary care doctor, which means less car rides, less everything. It's been a tough few years, but she's made it through. And that's why I chose the endocrine system and the different thyroid cancers. Thank you.